Hello, I'm Professor Derek Manus. I'm the current medical director of OTDT, and I'm a transplant and hepatobiliary surgeon in Newcastle. I'm going to talk a little bit today about some of the frontiers in organ transplantation, some of the developments that we're seeing around the world, and a lot from within our own country. Next slide, please. So, transplantation has always fascinated surgeons and physicians over many, many years, and this is the timeline. But in around about 1905, the first significant event occurred. Next slide, please. That was Alexis Carrel joining two arteries together. Seems a very simple thing to do now, but actually it was the beginning of transplantation. Next slide. And Alexis Carrel actually um, got a Nobel Prize for that work. Next slide. In 1940, Professor Peter Medawar, who you see at the top of the slide, um, identified a cell called a lymphocyte, and he developed an experiment which identified memory and tolerance. Next slide. And again, Peter Medawar, who became the first president of the British Transplant Society in the UK, who's Lebanese born, became British, and um, was known to be the father of modern transplantation. Next slide. In about 1954, the first human-to-human living donor transplant was done between two identical twins. Next slide. And these are the Heinrich twins. The recipient of this kidney, they were identical twins who needed no immunosuppression. The recipient of this kidney is still alive. And again, Joseph Murray, who you see there, who's a plastic surgeon in Boston, got a Nobel Prize for this work. Next slide. So the next significant development in the story of transplant comes in about the 1980s when Roy Kahn actually developed an immunosuppressive agent called cyclosporin. Next slide. And that drug was revolutionized really the way transplanted organs survived. Next slide. And the drug is based on a calcineurin inhibitor, which switches off IL-2 and prevents the lymphocyte proliferation. Next slide. And that drug's been modified significantly to now we use a modified slow release version, and it has been used all over the world. Next slide. Um, there's been many developments in transplantation. Next slide. 1967 was the first liver transplant. Next slide. And that occurred across the world, both in the UK with Roy Kahn, as you see in the bottom of that picture, and Tom Starzl. And that was in 1964 when they collaborated, but the first successful transplant was in 67. Next slide. The next development also was around the same time, next slide, with Chris Barnard transplanting the first heart transplant. Next slide. And next slide for me. And Chris Barnard had an intensivist who identified his second donor. That intensivist, his name was Bill Hoffenberg, and Sir Bill Hoffenberg became a professor of ethics in Oxford. He left South Africa and developed what we now know as the brain stem death criteria, which is the way we identify brain dead donors, and it was a huge advance in organ transplantation. Next slide. Transplantation is now based on that on that platform is become the standard of care for end organ failure. And in the United Kingdom, we transplant all these solid organs, as you can see. Next slide. The number of types of organ donors. The two main types are organ donors who come from who are brain dead donors, and these are donors that fulfill the brain death criteria, which I've just mentioned. Some of them are ideal donors, and they donate many organs. Some of them are what we call extended criteria donors, or ECDs, And these are donors who have certain organ dysfunction. And then you get marginal donors or very high-risk donors, and some of these donors are donors who have infections or had previous cancer, for example. And then you get DCD donors or circulatory dead donors. These are donors whose hearts have stopped, and they can be what's called controlled. In other words, you withdraw treatment in an intensive care, or uncontrolled, where they would have a cardiac arrest, either witnessed or unwitnessed. And you can see on the right-hand side, extended donors, and those are what are challenging us today in transplantation. These are donors who have issues with the function of their organs or their anatomy, or the organs have been injured, or they have disease such as hepatitis, for example, or bacterial infections, or worm infections, or they significantly older ages or obese. Next slide. And if you look at the deceased donation rate in the UK over the last 20 years, you can see in the graph on the left that the overall numbers have increased year upon year. The number of DCD donors, the circulatory donors, increased as well. And in this country, we have a significant number of DCD donors. But you can see from the cartoon on the right that actually about 600,000 people die a year in intensive cares in this country, and only about 1% become organ donors, and that amounts to about 1,400 a year. Next slide. Over the last 12 years in NHSBT, we've done a lot of development to increase organ donation, and you can see in 2008 we produced a strategy called the Organ Donor Task Force Strategy, which looked at increasing organ donation, and it did significantly increase, 95% increase in deceased donors and 58% increase in deceased donor transplants. Next slide. And that produced what we now have as the National Organ Retrieval Service, and it's a premier service where there are 9 centres who retrieve organs from all donors across the whole country, and it's the envy of the world. Really, it's a really well organised system, and also we've had a significant increase now in living donation. Next slide. Look, as I mentioned, the issues we face now are an aging donor population with almost 40% of the donors over the age of 65, and an obese donor population with a third of the donors being classified as obese. And as a result, the increase in complications for the organs, the dysfunction of organs, and the risk of cancer increases significantly. Next slide, please. OTDT have a number of responsibilities. The first is managing the organ donor register. The second is managing organ donation process, as I've shown you with the National Organ Retrieval Service and the specialist nurses in organ donation. We commission the retrieval service. We also support transplant centres by matching and offering organs and allocating organs to recipients, and developing new organ allocation systems, as we just have with the new liver allocation system. We also maintain the transplant list as a national database, or called the UK Transplant Registry, and we work with NHS England to monitor outcomes between transplant centres. Next slide. So what's been good and what's been not so good? So next slide. The good things we can say in transplantation over the years, we've improved immunosuppression significantly. The immunological risk assessment is much better. We allocate organs in a much better, more equitable way. Our donor management is significantly improved. We have cardiovascular assessment, which is much better, and pre-transplant workup. We've also reduced the incidence of T-cell mediated rejection. As you can see in the bottom graph, it's not a big problem anymore compared to the early years. And The other really good thing is that we've increased expanded the criteria for accepting recipients onto the waiting list. Next slide. What's not so good is the long-term outcome, and you can see that long-term, 10 and 20 years down the line, not less than half of the organs are working, and so there's a big challenge in sorting out the issue of graft failure. Next slide. And the other thing we're seeing much more commonly now is antibody-mediated rejection, particularly in kidney transplantation. Next slide. One of the other things that we thought we'd see a significant improvement on would be consent, and as I'm sure you all know, we've moved to an opt-out system with Max and Carer's law, and that became law in 2015. And what we can see from the graph on the left is that the referral rate and the SNOD presence rate in donor hospitals is at an all-time high, but the consent rate or authorization rate is not following suit. Next slide, and that's disappointing, and there's a lot of work being done on that. And you can see from the graph on the right that we have a growing waiting list of all organs, that's in the light blue bar, but the number of transplants in red still does not meet the need. Next slide. And one of the other things that it's concerning us in particular is the disparity in listing and outcome, particularly for patients in the Black and Asian communities. And you can see on the left, the median waiting time for a kidney transplant for a Black patient is significantly higher than for a white patient. And again, the consent rates on the graph on the right are significantly worse for Black and Asian patients. And those are things that we're working on tirelessly, really. Next slide. There's been lots of work, next slide, lots of work done looking at decision making around brain death and the lack of trust, particularly in those communities. Looking at the coroner service and how they can help impact on improving organ donation, and then the work with religious leaders. Next slide. The problem is that our deceased donation rate is still not as good as it should be. And if you look at our rate compared to the rest of the world, 14.4 per million is pretty low down compared to the rest of the world. Our DCD rate, as you can see in the red bar on the bottom graph, is pretty good. Next slide. And compared, when you break it down to organs in international comparisons, we're not doing badly with kidneys. We're certainly doing well with the pancreas. Liver is kind of middle of the road, but the cardiothoracic organs in particular are not good at all. And there's a lot of work we're doing now to try and improve that. Next slide. One of the other things that's not so good is that our use of DCD organs, our utilization, is not as good as it should be. And if you look at the graph on the top, those are deceased donor organs from brain death patients, and the utilization, certainly for kidneys and livers, is it's in the high 70s and 80s. When you look at the graph on the bottom for DCD organs, utilization is much lower for livers and certainly for cardiothoracic organs, not good at all. And if you look at the graph at the top on the right, you can see that around 400 kidneys last year were not used. They were retrieved but not used. So there's a big problem with utilization. And so a lot of the new developments in organ transplantation is about trying to improve the utilization. Next slide. So I'm sure we all know what happened in 2020 is that we had the pandemic. And next slide. The pandemic did cause quite a lot of upset across the entire NHS and certainly within organ transplantation. Before the pandemic, we had a 15% fall in waiting lists. There was and you can see the graph in the green line showing fall in waiting lists. We did also see an increase in transplantation and an increase in deceased donation. And then the pandemic hit and the waiting list went up significantly. And although there was an increase in transplants and increase in organ donors, it was still disproportionate to the waiting list. Next slide. And as a result of the pandemic, we have seen increase in waiting lists across all organs. And the ones where you have the red asterisk, those are the ones that are significantly increased. So our liver waiting list is now the highest it's ever been. The heart waiting list, again, continues to go up. And the lung waiting list is very high because of poor utilization. Next slide. So part of the challenges we face now in organ transplantation are the disappointing consent rates that I've shown you across all organs, especially in deemed family refusal. So deemed donors who are deemed consent, the family have refused, and we're looking into why that is the case. But partly it's probably due to mistrust in the NHS in general. And we have much more comorbid and high-risk donors, which need far more investment in getting an organ to transplantation. We have more complex recipients. We have very poor utilization, especially for extended criteria and DCD donors. We need to use more technology, and that needs funding opportunities. We have unpredictable long-term outcomes, which and that also needs more research. Inequalities in listing, complications in immunosuppression, and unit sustainability. Next slide. So we developed a strategy which is called Meeting the Need 2030. Next slide. And that strategy is about really focused on patients and the increased revolution in organ utilization. Next slide. So the mission statement says that we will aim to optimally utilize as many organs as possible. Next slide. And you can keep going down till they all come out. But the utilization is to improve utilization across all groups, to use these organ assessment and recovery models which we're working on, which I'll show you, support emerging technology, which you can see. Next slide. Develop an organ utilization program for clinicians and build on the experience we found in the pandemic. And one thing that happened during the pandemic is we worked much more closely as a clinical community. Next slide. And so the revolution really is a culture change so that we support clinicians to take more risk in with these high risk organs, to use the technology that has been developed to try and make more organs transplantable, and to learn from others, particularly regenerative medicine and the stem cell group. Next slide. And so the organ utilization group was set up, which was set up by the Department of Health, chaired by Sir Steve Powers, who's the medical director of NHS England. And it really was a multidisciplinary group engaging with many stakeholders, with many clinicians, and was very evidence-based as how we change the utilization. Next slide. And that group is going to be reporting on their recommendations, I think, currently with the minister as we speak. Next slide. Within NHSBT, what we've done is we've set up a utilization program which looks at using novel technologies, which I'll show you now, education, and particularly culture change, clinical leadership with setting up of the clinical leads in organ utilization, and then looking at how we collate data, how we use data, and how we help clinicians to make decisions with the data we have. Next slide. And so, as I mentioned, culture change is one of the big things that we have to work on. It's about winning hearts and minds, particularly of clinicians who have been working in a certain way over many years, of how you change their mindset. Next slide. So the revolution comes with the changes over the last 20 years. So when organ transplantation started, the way you transported an organ from a donor to a recipient hospital would be in the ice box that you see there. That's a modern ice box, but in the old days it was simply a box with ice in it. And we've had to rethink the way we preserve organs now because of the high risk organs that we have, which don't take kindly to being shoved in a box of ice for too long. So we have rethought what to do. Next slide. The limitations of putting an organ in an ice box is that once you cool them, you lose the membrane stability. Next slide. You have no oxygen delivery, so it becomes an anaerobic metabolism environment. There's accumulation of metabolites causing ischemia, reperfusion. Next slide. And there's lots of limitations in viability assessment, and so you get a lot of injury. Next slide. And so what's happened is that there's been a development in how we change this, and normothermic machine perfusion has come to the fore. Normothermic meaning we now take an organ from a donor and we perfuse it at body temperature. So recreate the physiological environment, we deliver oxygen, we give physiological an environment that is it's used to, and particularly with temperature, and we provide nutrients. And this allows normal metabolic activity to continue and certainly avoids a lot of ischemia reperfusion, and it enables us to assess viability. Next slide. So there are a number of machines now available. I've mentioned normothermic, which is warm, but also the cold machines, and they're subnormal machines. You can see many of them in the slide. And the situation is quite varied at the moment. So you can put an organ in a box of ice, transport it to the center, so that's called back to base. And at the base center, you can then put on a machine and assess its function. Or you can actually, at the bottom of that cartoon on the left, just put the organ straight onto the machine and transport it on the machine. And that is a machine that was developed at Oxford called the OrganOx and is now used worldwide. Next slide. There are lots of potentials for this machine to recondition organs, particularly adding the change in the genetic code, change in the signaling, and using decellularization. Next slide. One of the things that in particular for the liver is to test the viability, and livers, if they don't work, just like a heart, if it doesn't work, unfortunately the patient will die. And so the risk aversion comes because clinicians are unsure whether these organs will work. What these machines do is give you an ability to assess the viability. And there are lots of studies now looking at that, particularly many studies from the UK, particularly Cambridge and Edinburgh. Next slide. Other than warm perfusion, there's also cold perfusion or hypothermia, and that has a number of limitations, and we're still unsure as to which is best. And part of what we're doing in NHSBT is to establish working groups to look at how we assess this. Doing randomized trial is going to be very difficult in this field. Next slide. We also started machine perfusion for other organs. This is first in man in the kidney, and this was performed by Mike Nicholson and his group at Cambridge. It's a unique opportunity really to deliver therapies in isolation. And what's one of the benefits of a machine is that you don't have the problem of the phagocytic system within the body that can destroy treatments that you put into the kidney or the liver. Next slide. And there's a current study going on at the moment looking at gene expression by antisense oligosaccharides, and that's delivered during machine perfusion so that you don't lose that, they don't get damaged by the body's immune system. Next slide. We also have a machine for the heart. This has really revolutionized heart transplant. So DCD heart transplant was non-existent before 2015. As you can imagine, a donor who's circulatory dead or heart dead will not be able to donate a heart. But what this machine does is it allows you to take the heart out very quickly and put on a machine and restart it, which is what it does. This is called the OCS, or organ care system. Next slide. Um, it, with NHS England, we developed a joint innovation fund because it's quite an expensive machine, and it's revolutionized the number of heart transplants. Next slide. So you can see that in 2015, there was one DCD heart done. By 2022, we've done 42 this year. That's been an amazing improvement. Next slide. There are other heart devices. The ex vivo is a cold device, and there's a lung device as well called ex vivo lung perfusion. All these are being assessed now um, within the clinical community with assistance from OTDT. Next slide. Other than the organs being retrieved from a donor and put on a machine, we can go to the donor with a machine and recreate a heart beating situation. So this is called normothermic reperfusion. And what this machine does is once the donor has died, and this is for DCD donors, they're connected to this machine, which is essentially a heart-lung machine. It's a machine that perfuses. It's a bypass machine that's used during heart surgery, and you restart the circulation and perfuse the organs again for an average of 2 hours, and recreate the oxygenated environment. Next slide. And what it's done is shown a significant improvement in function. This is of the liver. You can just see at the bottom the overall outcome of normothermic regional perfusion livers, 93% 1-year survival compared to 84%. And next slide. You can see in that slide the liver that looks very yellow. Those livers do not function very well, particularly when they come from donors who are already dead, the DCD donors. But if you could recreate the oxygenated, perfused environment, you can get results that are equivalent to brain dead donors. Next slide. With the kidney transplant, we've shown very similar things as that actually with the normothermic perfused kidneys compared to the standard cold storage. The results are better. Next slide. And actually the function of the kidney is actually better. So there you can see the mean EGFR. The plan is to set up organ assessment and recovery centers with all these machines in place so that the organs can be sent to these centers to be assessed by a professional team. So it takes away the stress from each individual retrieval center. Next slide. And we can realize almost, in looking at the business case, 1,000 more transplants over 10 years. Next slide. There's lots of research which can be done using these machines, and this is just some of them. The top shows the Vittel study. These are livers that were turned down by every center as unusable. Putting them on the machine and assessing them, 71% were used. And without the normothermic machine, that would never have happened. This slide below shows a defatting drug. You can see the liver, very yellow liver. You can put on a machine and remove the fat, and that makes it much safer to use. Next slide, please. The other thing that you can use on a machine is the use of nanoparticle therapy. And these are targeted drug-loaded nanoparticles, which can block many things. In this case, this is a study which was used to block NF-kappa B and neutrophil binding. That's now being extended, so that study now is going to be used in the UK at a multi-center trial. Next slide. The other thing we're using the machines for is for extracorporeal liver support. When someone goes into fulminant liver failure, they have a very short time before you need a liver transplant for them, about 72 hours. If that liver is not available, unfortunately, the patient will die. What we are exploring is using a liver in a box, essentially, putting the liver on a machine and then connecting it to the patient as a bridge to transplantation. And that study is now open in 4 centers. Next slide. Moving away from machines, we're moving to minimally invasive surgery, so robotic renal transplant. And those of you may know that the College of Surgeons is focused on minimally invasive and robotic surgery. And so we've moved into that realm in transplantation. Next slide. And it's particularly useful for living donor kidney transplantation. Next slide. But also, there's the many centers now in Europe and the US using robotic technology for live donor liver transplantation for the donor hepatectomy. We are not at that point yet, but we are moving towards developing our living donor liver transplantation program, and I'm sure this will come into play at some point. Next slide. We've also changed some of the indications for liver transplants. So we're moving to the realms of transplant oncology, keeping up with the rest of the world. So indications like biliary cancer, colon cancer spread to the liver, and neuroendocrine tumors. Next slide. And we're innovating using proton beam therapy, which is the first time that'll be done in the world in patients who are eligible for cholangiocarcinoma transplantation. Next slide. The other thing which we're moving to is enhanced recovery, and those you may know within surgery in general, there's a big move towards uh, um, pathway designed specifically to improve the quality of surgical recovery and reduce the body's stress response to surgery. There's not been done a lot in transplantation, and we're now in NHSBT developing a national program, and that is based on preoperative assessment of patients, prehabilitation, in other words, giving them exercises, and education, followed by intraoperative changes to prevent them needing lots of opioids, and then post-op to get early nutrition, early mobilization, and early home, and reduce the burden on the NHS. And a lot of the patients, if they're prepared, can get home much earlier. Next slide. We also moved into a national program for frailty assessment. A lot of the patients, when they get end organ failure, become very frail and what's called sarcopenic. And as you get older, it naturally becomes sarcopenic. That results in you being deconditioned for a very extensive operation. And so part of the plan is to assess patients, next slide, and then give them a prehabilitation program, which is essentially an exercise program to get them into a fitter state. Next slide. The other thing that's we're very proud of in OTDTs are living donor kidney transplantation, and you can see the numbers there over the years. The dip you can see is from the pandemic. Next slide. One of the things that we are really very good at is developing what's called the UK Living Kidney Sharing Scheme. That started in 2007. If you have a donor and a recipient who are not matched, you can then match them with another donor recipient and essentially swap the kidneys. And the law changed in 2007 to allow that to happen. It then changed again in 2012 to allow patients who were not related or anyway knew each other, called non-directed donors, to then stimulate a chain, as you can see. In 2015, we've got multiple chains, and that's been revolutionary in kidney transplant in this country. And it is the biggest scheme in Europe. Next slide. And you can see, next slide. the number of transplants that these schemes can stimulate just by having a non-directed donor, or what we used to call altruistic donors, but all donors are altruistic really. So you can see the number of transplants you can get out of that. Next slide. And then our living donor liver transplant program, which is starting up again. We did have one. It fell into a slight slump, but it's coming back. Next slide. And the other thing we've moved towards is digital pathology. I mean, donors are aging, as we said. They have risk of cancer. You have to take biopsies in the middle of the night and get the specimens looked at very quickly. That can be a challenge. Moving to a digital pathology service so that pathologists can look at the specimen in the comfort of their own home in the middle of the night, and that's a program which is currently being set up through NHSBT. Next slide. Next slide. In development, uterine transplant, which has just started. We have a forearm transplant program, which is set in Leeds, and there's a emerging face transplant program. Next slide. And then finally, just to talk a bit about the reconditioning, stem cells. Transplant surgeons became very interested in stem cells because these are cells that can be reprogrammed, as everyone knows, into and differentiated into whatever cell type you like, and generating iPS cells, which are induced pluripotent stem cells, was the first iteration of this. Next slide. And it was used particularly for decellularized organs. So you can see on that slide, there's a liver that's been decellularized and then repopulated with iPS cells. This is still in its infancy, and as you can see, there are lots of problems with this, particularly what cell mass you need, and the thrombogenicity of these cells. Next slide. There was more interest in mesenchymal stem cells, which are interesting cells because they adapt to their microenvironment and they differentiate into different lineages, and they have quite a effect on release of cytokines. And there's been very little work done on mesenchymal stem cells in machine perfused organs. And so, next slide, that is the current plan. Because if you perfuse these infuse into the body, there are lots of hurdles to how you can get these to be beneficial. But with a normothermic machine perfusion, this could be a solution. Next slide. And then the multipotent adult progenitor cells, and there's a study currently going on in Newcastle looking at the feasibility of this. Next slide. It's a paired kidney study. Next slide. And I think again machine perfusion plays a big role in this because it could be a paradigm shift, providing really quite an exciting opportunity to deliver these cells. Next slide. And then finally, the other stem cells that have been used quite extensively are the adipose-derived mesenchymal cells, and these are particularly for within the liver, trying to improve diseased livers that probably will allow you not to have to transplant them, but regenerating livers. Next slide. And finally, ischemia reperfusion injury. Next slide. This is a big problem we see across transplantation, and a number of drugs that can be used. This is a PPAR gamma agonist. It's called seladelpar, which has also been used in machine perfusion now to try and ameliorate ischemia reperfusion. Next slide. Regulated T cells are another way of delivering drugs that can cells that can suppress the immune system, and again, machine perfusion is another way to do this. And it might be possible to isolate this population of regulatory cells and program them to inhibit the immunity against any foreign protein, again delivered through machine perfusion. Next slide. And there are a number of studies going on worldwide and 3 in the UK. You can't really see them on that, but 3 being done here. Next slide. And finally, xenotransplantation, and many of you have, I'm sure, heard about the transplants that have been carried out in the US last year in 3 centers in Maryland, in Alabama, and in New York. And xenotransplant has been around for many years, but never got traction because of a number of problems. The UK was really in the forefront of xenotransplant in the 90s with David White, who developed the alpha-gal knockout pig, but it's progressed significantly since then. Next slide. You can see the progress since 19 to the 1990s to 2014, and now we have what's called the 10 gene edited pig. Next slide. Where there are a number of deletions, a number of human transgene additions, so that the pig organs are not seen as foreign, but are almost humanized. And we've removed alpha-gal, which is the carbohydrate that's activated that activates the complement cascade, and the reason why there were so many hyperimmune rejections. Next slide. And this process of CRISPR-Cas9, which I won't go into, but I'm sure many of you know about, which has led to the revival in xenotransplantation. Next slide. And as a result, there have been the 2 cases of pig to human kidney transplantation using organ donors. These were donors who had consented and donated their bodies to science, and they transplanted pig kidneys into them with essentially good outcome. It was a short-lived study, only 52 hours, I think. And then next slide, the heart transplant patient who was a patient who was transplanted, unfortunately got porcine CMV, we think, but he did have a functioning heart at the time. Next slide. So I think there is the future that's coming. The 10 gene edited pig is, I think, the future certainly for kidney transplant and heart transplant. I'm not going to give any predictions of when this will happen in the UK. We've just set up a group again within NHSBT to engage with the DH, MHRA, and the regulators. Next slide. And the last 2 slides, bioprinting. I think bioprinting is definitely on the cards for the future. In terms of solid organ bioprinting, I think it's a bit away. We have used bioprinting to produce, for example, vessels, trachea, but I don't think we're ready for bioprinting of human organs yet. But it's something which I'm sure will come, certainly not in my career. Next slide. And development of tolerance, which is the holy grail, is what we've been looking for a long time, and that will come. We're continuing to look for ways of developing clonal energy, clonal deletion and suppression. We've done many studies. Unfortunately, not many of them have been successful, but I'm sure we'll continue to strive for tolerance. Next slide. And so I think about transplantation and transplant science it is about optimism. And there you can see the saints Cosmos and Damien, a very famous painting of transplanting a leg onto a recipient. Next slide. And actually the optimism in this painting is the fact that there are 2 slippers on the ground. That means they are optimistic this will be a success. And my mentor, Tom Starzl, said, history tells us that procedures that were inconceivable yesterday and are barely achievable today are often routine tomorrow. So thank you very much.